So why don't we get started for all those of you that showed up on time. Welcome to our SADS Foundation first webinar of the Living with SADS series. I'm Marcia Baker, and I'm the program director for the SADS Foundation. Before beginning the webinar, What Makes Your SADS Heart Different? I have a couple reminders. One, please keep your audio muted, as most of you already have done so during our presentation.
Love you too. All right, bye.
Click your little mute button there. And following her presentation, we have allotted time for Q&A. You may unmute yourself to ask a question verbally at the end, or you can add a question in the chat anytime during the presentation, and we'll address those at the end. Today's webinar is being recorded, and it may be accessed later on SADS Foundation's website, stopsads.org. I'd like to present our distinguished speaker today, Dr. Aarti Dalal. Dr. Dalal is a pediatric cardiologist at St. Louis Children's Hospital and an assistant professor of pediatrics and cardiology at Washington University in St. Louis. She specializes in pediatric heart rhythm disorders, electrophysiology studies, catheter ablation, and pacemaker defibrillator implantation. Aarti received her Bachelor of Arts degree from Boston University. Her doctorate of osteopathic medicine was received from Rowan University in New Jersey. Aarti's training as a pediatric resident was at the University of Maryland Children's Hospital, followed by a pediatric cardiology fellowship at Emory University in Atlanta, and a clinical fellowship in pediatric electrophysiology at Vanderbilt University in Nashville. Now it's my pleasure to welcome our fabulous volunteer, Dr. Aarti Dalal. Aarti?
Thank you, Marcia, for that very kind introduction, and to the SADS team. I really appreciate the invitation today. And welcome to all of you to the very first family webinar series this year, and What Makes Your SADS Heart Different. Just a quick disclaimer, in no means is today meant to be exhaustive. There will be subsequent talks about specific disease processes. So for any reason, if we don't talk about something today, one, obviously ask the question, but we will be talking about each of the diseases in a little bit more detail. And I think Marcia and the team will be sending out those dates with the topic after this. So again, thank you for the very kind introduction, and we'll get started. So our topic today, as mentioned, is living with SADS and what makes your heart different. And this truly is just an overview of what you are talking about with your physician when you meet them. And I think the thing that I want to sort of stress today is, one, being present today, being part of SADS really makes you someone that is interested in the diagnosis. You are your best advocate and your child's advocate. And remember, you will be going to parts of the country where you may not have access to a specialist. So making sure you actually understand the basics and what makes your heart different to allow you to live sort of your best life is really important. So we'll get started. I have no disclosures. So I think we want to start at the basics. Now, I had mentioned this earlier before we got started, just to sort of make this fun. Can anybody identify the movie where this little DNA cartoon is from? You can put it into the chat if you want to. Marcia can tell me if anyone types into the chat. It's from Nice job. Yes, very cool. So the original, none of this new nonsense, right? The original 1993 Jurassic Park. So I was going to try to play the video, but it would take too much time. But yes, exactly. So basics, right? We all have 23 pairs of chromosomes. We have autosomes. We also have this pair of sex chromosomes. And so this is what makes us who we are. So when we think about the diseases that we're talking about today, we understand that we have chromosomes. They code for, they contain genes, which then code for proteins. And it's if there is any type of alteration in the function of that protein that then dictates, how we manifest and what our genetic predispositions are. So for some of us, it might be diabetes. For some of it might be hypertension. For others, it might be these inherited arrhythmias that we're talking about today. And so that's where all of these stem from. And so as part of your workup, a lot of you will meet with genetic counselors and geneticists. and they'll create these wonderful pedigrees for you that look like this. And so this is what an example of an autosomal dominant inheritance pattern looks like. It means that every generation is affected. Now, that doesn't mean that each member of every generation is going to present the same. This is when we talk about the difference in penetrance. So there's something very different being phenotypically positive versus being genotype positive. But if you know what your disease is, and you understand the inheritance pattern, then you get a better understanding of who can be affected and why it's so important to do cascade testing and making sure you get in touch with that cousin that you may not have talked to in 5 years, or that aunt. So it's important to understand when we talk about inheritance patterns, why we talk about them, so you understand who could be at risk in your family. And so this sort of goes to this idea that, again, every generation is affected, but again, how they manifest will be a little bit different. And then we talk about what diseases are we actually talking about today. So the inherited cardiac disorders of interest are the ones that have the arrows by them. So you can see a lot of them we're going to be talking about in this series, and some of them we won't be. If for any reason we don't talk about your disease process and you want to know more about it, you can reach out to any of the SAD staff members. And if we specifically don't have a contact, we'll make sure that you get in contact with someone that can help you. So again, there are many diseases that are related to, that are inherited or so have genetic predisposition. And so part of this, remember guys, is that we are trying to empower you to make sure that you are a very informed consumer. And so this is a team sport, and part of it is making sure that you also are quite involved. So all of your physicians, the pediatricians for your children, and your physician should be making sure that you are having a cardiac risk assessment form. That truly is just making sure that we are asking, if you haven't had genetics done, are you at risk? And so there are questions that we ask about the patient, we ask about the family members, and then you'll often hear your physician talk about red flags. And so those are things, what might make us more concerned that your presentation of syncope, for example, is not just a garden variety vasovagal syncope. So all of these together sort of help us make sure that we're taking good care of you. I saw there was a chat, someone sort of said something. Marcia, anything I need to address right now?
No, you're good. I just put in sads@sads.org.
Oh, perfect. Okay, thank you. So as all of you know, right, you can't appreciate the present or how we move forward unless we understand how we got here. So I think one of the things that's really quite amazing about the diseases that we're going to be talking about today is that this is still a relatively young field. When we talk about the advances that we've made, it truly is just in the past few decades that we've really gotten to where we are today. So the first, I guess, recorded channelopathic death might have been as long as 1889. But truly, if you start looking at the data, it comes from the 1960s and onwards, when Drs. Romano and Ward sort of described the first few cases of long QT syndrome independently. And then sort of the man that put SADS together, Dr. Michael Vincent, sort of gathered long QT syndrome families in the 70s. We had reports from Asia about young men that were dying suddenly. It was, sudden unexplained nocturnal death syndrome. And as we started putting that information together in 1986, the first diagnosis of Brugada. Then we started understanding, when we talk about bench to bedside, bedside to bench type of research, finding actual genetic locations of long QT syndrome, for example. And then in the late 90s and sort of the first part of this century, we were able to sort of identify more causes, more mutations, understanding more genetic, more genes as to what was causing the diseases. And then again, just in 2000, short QT syndrome. And now we are at a point in medicine where we're starting to explore precision medicine, meaning how can we make sure that we are personalizing care for you as an individual, not generic long QT syndrome, but you with your long QT1, and these are your triggers and things like that. So understanding that medicine it's quickly changing. And then I think we have a couple people on the call, but you'll hear, I don't think, not today, but later on in one of the series, you might hear from Dr. Robert Hamilton, who is really doing some very novel work with understanding, are there better ways that we can identify affected patients? So one of the benefits of coming to, I think, talks like this is SADS truly is, they're the group in the know and connections to the researchers. And so one of the things that we'll talk about is there's access to the latest scientific articles. So you, as a member of the SADS family, truly should become informed as to what is happening out there in the community. So let's think about this history, right? So this history exists for each of the diseases. So long QT syndrome, for example, I just think it's really interesting how it's come such a long way and what we know about and how it sort of evolved. So this is long QT's history, as I mentioned, in the late 50s, early 60s, and then very quickly as we think about different management styles. So doing sympathectomies and understanding the use of beta blockers and placement of ICDs. So again, we're in a very different place now than we were 10 years ago, 15 years ago, 20 years ago. And the reason that's important is if you have the disease, right, and you are a carrier and your child has it, if your child is being managed a little bit differently than you were, that doesn't mean it's wrong, or it doesn't mean the way you're managed is incorrect, but we modify how we take care of our patients based on what we know, and that changes every year. The same thing for Brugada syndrome, right? There's how we manage these patients also is changing. So just know there is, as we move through, right, we are learning a lot, and therefore how we manage our patients also changes. And this just goes back to the idea that there are scientific papers about best practices. You have access to that. So know that you can go to HRS website. Again, SADS is a great place. If you just go to their website, there's actually a section for scientific articles, and it's all there. And then again, just reach out to Marsha and the team, and they can update you. Okay, so the reason why we were actually here today. So let's talk about the heart. So this is a conversation I'm sure many of you have had with your cardiologist, with your electrophysiologist. So if you have, and this is a little bit redundant, you can just mute me until we get to slides that you're interested in. Okay, so we talk about cardiac anatomy in the conduction system. So this is a cartoon of what the heart looks like. You obviously know this is not what the proper heart looks like, but this is what we call a four-chamber. So you have the chambers of the heart and you have the conduction system. So we're going to go through this a little bit. Now, this is what I do for all of my patients. When I sit there, I drew this on like paint. And so I draw a little cartoon of the heart. You have four chambers. There's two top chambers called the atria and two bottom chambers called the ventricles. They are the pumping chambers of the heart. And the heart is driven by a normal pacemaker, which is called the sinus node, which is here in the top right chamber of the heart. Conduction travels through the small chambers, goes to the middle part of the heart, and then travels through the big chambers. And so the atria, the top chambers, and the ventricles are connected electrically by this AV node. And there are specialized pathways that allow conduction through the big chambers, the ventricles, to coordinate in a quick and coordinated fashion. But what we are talking about today is a little bit more specific and a little bit more in detail. So we're talking about the cells that actually make up the heart itself, the cardiac myocytes. So we're going to be talking about why understanding the structure of the heart and the myocytes and what they're actually composed of and how it relates to your disease process. So as mentioned, the heart is an electromechanical pump that is triggered by the generation or propagation of action potentials. So that action potential is going to be really important in the disease that we're talking about today. So this is followed by a period of contraction and relaxation, which allows for the generation of the next impulse. And these action potentials that we're going to be talking about is generated by ionic changes across the membrane. So ion channels really drive a lot of what allows the heart to function. So, and cardiac myocytes then are connected physically and electrically. Now this physical connection is really important. So when we talk about myopathies, now I know today's going to be focusing a lot on channelopathies, but I think there's somebody today early on that mentioned that they have a diagnosis of arrhythmogenic cardiomyopathy, right? So when we're talking about sort of how cells are connected themselves, or if you have other myopathies, right? That is actually talking about the structure of the actual muscle. So electricity moves quickly between heart muscle cells and allows the heart to contract simultaneously. That's really important. So let's look at this at a microscopic level. So the cardiac myocyte, right, within it has different ion channels. So these ionic changes, right, are because of sequential activation and inactivation of ion channels, whether it's a sodium channel, a calcium channel, a potassium channel, which allow for inward currents of sodium and calcium and outward currents of potassium, which maintain a special sort of electrical current within the cell. So this thing here on the right side of the screen is an action potential. And this is what allows conduction to sort of occur in the heart. And so what I want you to now see is it's this excitation contraction coupling that allows the actual cell to contract, which then allows the heart to contract. So this concept of excitation contraction coupling is very important. So that previous slide was truly just of the membrane, allowing you to look at the different ions. But when that happens, you then have the action potential then that stimulates release of calcium in the cell, which then allows actin and myosin to come together and actually have contraction of the myocyte. So it is a fascinating sort of interaction of how this all works. But why is this important for you? How does it apply to you and your diagnosis? So when we talk about channelopathies, right, it affects those actual ion channels. So changes in action potential, how things are synchronized, how it propagates through the cell, that is what predisposes someone to malignant arrhythmias. And if it stems from a genetic problem, right, so if the genes encoding for those ion channels are altered, then that's what can lead to Brugada syndrome, long QT syndrome, short QT syndrome, and CPVT. So again, this is an overview, and I'm not going to be going into a lot of detail about each of these. But when we think about the action potential and how it relates to your disease, it's important to look at all of these different sort of parts of the action potential and the different genes and mutations that occur and how it might then relate. And so if we think about this picture, and then we take it back to that, remember I showed you the picture of the cell? If you have, for example, a potassium channel mutation and it affects how that action potential can actually go through, it can then affect, right? This is where you might see that. For patients with CPVT, it's because of a calcium channel mutation. If you have ARVC, it's still related, right? It's affecting the desmosomes. So all of this together, right, allow that cell to function either properly or improperly. So hopefully that puts all of this into a little bit better perspective. Okay, so again, these are very brief overviews. I'm not sure how far, okay, so we still have quite a bit of time. So again, there will be dedicated talks about each of these diagnoses later on, and Marcia and the team will be sending that out at a future date. So long QT syndrome, this truly is the prototype channelopathy. We have specifically even in the US, and I know we have some international members or families that have also attended. So I'm specifically talking here about in the US. We have sort of the most patients, the genetic and clinical information we have is truly a remarkable amount. And then the natural history. So a lot of the, our, I guess, long QT patients, you guys truly are at an advantage when we talk about management. Now, you remember that history slide I showed you. We have a lot of genes that have been identified, over 15. It truly started as just a few genes. So we talk about long QT 1, 2, and 3, but there are a lot more. But about 95% of patients with long QT truly are either 1, 2, or 3. So when we talk about it, we often focus on them, but please know that if you don't have 1, 2, or 3 and you have another variant, again, just as we can sort of have this conversation with you as well. So again, when we talk about the most common 1, 2, and 3, it's either a loss of function of your potassium channel or a gain of function of your sodium channel. So remember, this goes back to our favorite subject, the action potential. So when we talk about long QT syndrome, we're talking about how it manifests on an ECG or an EKG. because when we talk about it, right, this is your QRS, and then this is your T wave here. So it's oh, sorry, you can't see me moving my mouse. I have to remember to look at to move the right one. Sorry, so this is your QRS, and this is your T wave. So this is how it manifests on an EKG, but it actually goes back to the action potential. So if you have a loss of function of your potassium channel, so you have decreased outward current, it's going to extend that action potential or the repolarization, how long it takes for that cell to recover, and thereby prolonging how it looks on EKG or making that QT interval longer. And that's why it's called a prolonged QT interval and long QT syndrome. For your long QT3, where you have a gain of function, right, you actually have an increased function of that sodium channel. But it all, again, goes back to what that EKG looks like. But how does that manifest as disease then? So if this is a normal action potential, if it takes too long for that action potential to sort of recover or get back to baseline, you then can have these things called early after depolarizations, which then lead to the thing that we don't like, are ventricular arrhythmias. So all of these diseases ultimately lead to dangerous ventricular arrhythmias, which is what puts you at risk for adverse cardiac events. But that is why patients with long QT syndrome can then have these ventricular arrhythmias and ventricular fibrillation. So when we talk about presentation, though, remember I told you it can be quite variable. So some patients are going to be completely asymptomatic. So I don't want people to think that if they have a known gene mutation, and so what I will often find is if I see a patient in clinic and I'm seeing their child, the child may be symptomatic and they're being really good about taking their medication. The adult who follows with an adult cardiologist, maybe not an electrophysiologist, or someone that's sort of well-versed in channelopathies. They're like, well, you know what? I haven't had an event. I'm 50 and I'm doing great. So I don't need to take medications. I don't really need to follow with anybody. That's not true, right? If you know you have the disease and there is a family mutation, you want to make sure that all family members are getting appropriate care and appropriate follow-up. So again, there can be quite a difference in the phenotypic expression of the gene-related disease. So again, some patients might be asymptomatic and others are going to actually have the disease. Some patients might present as a fetus, as an infant, so it can have significant fetal arrhythmias. You might have a history of sudden infant death syndrome in the family. So again, there is quite a variety of how these patients might present. And then that goes back to the EKG, right? I never want people to think that an EKG is going to be sort of that answer. Up to 25% of patients may have completely normal EKGs and they actually do have long QT syndrome. So remember, speak with your genetic counselor if you have access to one. If you don't, reach out to the SADS team. They can make sure that you can even do a telemedicine visit with a genetic counselor if you feel like if you haven't had the opportunity to meet with one. And so you have a 50-50 chance because a lot of these diseases, specifically for long QT, are autosomal dominant. So you have a 50-50 chance of passing it on to your offspring. So family screening, cascade testing is super important. But again, the reason I don't want you guys to focus on a number for long QT syndrome is because you can have a completely normal QT interval and still have the disease, as you guys know, or have an abnormal QT interval, corrected QT interval, and you may not have it. So when we talk about just, mass screening, everyone getting an EKG, that's not what we're talking about because that alone will not identify affected family members. Again, I keep saying this, but I just want you to know this is not meant to be exhaustive. But when we talk about long QT syndrome, one of the reasons it's important to know the type that you have, know your genetic mutation, is because there's going to be different management styles. So what you're at risk for when you may have, when you're high risk for having an arrhythmia, knowing what medications you might respond best to, what your EKG will look like is dependent upon the type of disease you have. And so often, right, as electrophysiologists, we know, 1 versus 2 versus 3. And also there are going to be different risk factors. So we know that gender can play a role into risk, knowing what, again, your QT interval might be when you present with your first symptom. And so there are risks based on your specific mutation, whether it's a poor mutation or not. And so speaking to your cardiologist in detail about your disease and you knowing the most will help you understand your risk and your family's risk. Because ultimately, all of this is meant to make sure that you guys feel confident in the diagnosis, and we can make sure that you and your child are, have the best quality of life. Again, we're not focusing on this a lot, but management is then non-selective beta blockers, managing triggers, sympathectomy if needed, and then ICD. You'll find that, so the other thing I want to talk about, because we had talked about history a little bit. Remember, early on, you had long QT syndrome. People were placed on beta blockers that got ICDs. Now, as we're doing better with non-selective beta blockers, even doing sympathectomies, you may not need to do an ICD as early, or if we have you well sort of controlled on just medications, you may not need an ICD. So if you are thinking, well, I got an ICD placed when I was 20, and why does my daughter not have one yet? Again, we're learning a lot more, but also we might be doing a better job in managing the disease. So that's long QT syndrome. Again, there's going to be different talks on long QT1, long QT2, I think long QT3 as well. So we'll talk about all of that in detail. All right, so next disease process that we're going to be talking about is catecholaminergic polymorphic ventricular tachycardia. It's just a lot of words, but essentially what it means is adrenaline-related ventricular tachycardia, or abnormal rhythm coming from the bottom chambers of the heart. So it is related to stress and exertion, so when you have a high amount of adrenaline on board, and it's related to a defect in calcium handling. So some patients present with syncope, other patients might present with seizures, some patients present with a full-on cardiac arrest. But understanding that that's your diagnosis well, and knowing what your triggers are and making sure you're on your medications can help sort of mitigate a lot of those risks. Now, I'm showing this slide mostly again to tell you that it does go back to that basic sort of science that we were talking about. Understanding that it's related to the calcium handling in the cell. So this is something called the sarcoplasmic reticulum. Remember, this is sort of what we talked about with our long QT patients. Down here within the cell, calcium release is related to CPVT. Now, the distinguishing feature of this disease is that your EKG is completely normal. So if I get an EKG on you, your QT is normal. You don't have long QT syndrome. You're not going to have any issues in the baseline state. Your echocardiogram is also going to be completely normal. But it's when I expose you to stress, if I have you run on a treadmill, if I take you to the EP lab and I do a drug challenge, that's when you're going to see the arrhythmias. And the prototypical, so the typical EKG or arrhythmia that you're going to see is this bidirectional ventricular tachycardia. And that's, again, the name. But so you see this sort of alternating pattern of the ventricular arrhythmia. And then, again, management is non-selective beta blockers, sympathectomies. If you present with an arrest, you get an ICD. And now Brugada syndrome, I don't know if we have any patients with Brugada syndrome on the call, Marcia, but this is typically a disease of the young. We know that patients typically present in the second and third decade of life. There is a typical sort of EKG pattern, but even if you don't have a spontaneous abnormal EKG that's consistent with Brugada syndrome, doesn't mean you don't have the disease. Patients can present, again, quite variably with syncope. They can have an arrest. They can have sort of non-sustained ventricular arrhythmias. They also might even have atrial arrhythmias. And remember, this is a disease of a sodium channel mutation. Now, there are other genes that have now been identified, but the first one sort of was an SCN5A mutation, which is a sodium channel mutation. And so patients with this have arrhythmias, but also can have both atrial and ventricular arrhythmias. So what would be, for example, a typical presentation in a pediatric patient? So one would be, and this is a true case, you have a 5-month-old that was febrile and was undergoing surgery for a wound, IND. And during the surgery, they had a cardiac arrest, required CPR, and had ventricular arrhythmias, and then normalization after the fever was controlled. So in the baseline state, a patient with Brugada syndrome might actually have a completely normal EKG. In the setting of a fever, this is what happens. So if you can't see it on that slide, let me sort of do this thing. So you have this ST segment elevation, this cove type change on your anterior precordial leads. So if your cardiologist says to you, I want you to aggressively manage your fever, it's because we know that patients with Brugada syndrome are at higher risk for having these arrhythmias in the presence of fever. And again, all of this is because it ends up leading to the exact same thing that you're going to see in the other channelopathies, which is ventricular arrhythmias and fibrillation. And so this is sort of what that looks like. As mentioned, it was initially linked to a loss of function in your sodium channel, so your SCN5A. Now there are multiple variants that are in genes that have been implicated in this condition. I do believe we have a Brugada syndrome lecture also slated for you guys. So if that is your diagnosis, please know that we will be talking about this. But there are sort of two big theories as to why patients with Brugada syndrome have arrhythmias, both the repolarization and depolarization sort of hypothesis. We know that they tend to have these ventricular arrhythmias that originate around the right ventricular outflow tract. So if you're old enough, your physician may even sort of refer you for an ablation to see if they can sort of manage that. But it's because you have this sort of dispersion between your epicardial, endocardial myocytes, and then it can lead to dispersion and then ventricular arrhythmias. We don't have a clean-cut sort of management style for Brugada syndrome, so it's not like you can take a beta blocker like you might in long QT syndrome. We want to avoid medication, so there is a Brugada drug list that you want to avoid, and then as mentioned, fever control. You can also, we will outfit you with an ICD if it's necessary if you're demonstrating ventricular arrhythmias. In Europe, there are, you have access to some different medications. So we will also use things like quinidine, which we are using a little bit more in the US as well. But so depending on your location in the world, in the globe, you might have access to some different medications as well. And then arrhythmogenic cardiomyopathy. I write ARVC because that's colloquial how it's talked about, but just know that it is arrhythmogenic cardiomyopathy. It traditionally was thought to sort of just affect the right side, but it can also affect the left side. So again, the new name really is arrhythmogenic cardiomyopathy. And then again, I don't mean to keep calling out Dr. Hamilton, but he's also doing some pretty impressive work with arrhythmogenic cardiomyopathy as well to help identify patients that may be gene negative, but actually have the disease. So again, the SADS group is a great group to contact, to connect you with him as well.
He is on the call today.
Perfect. So he must think that I'm like his personal cheerleader, but he's doing some really incredible work. So I do think it's important to identify our friends in the field that are really helping to move it forward. So again, ARVC, this is not a channelopathy, but instead it actually is a myopathy, but it's the progressive sort of replacement of normal cardiac tissue with sort of fibrofatty tissue. And we know that it is a progressive, again, inherited disease that can lead to ventricular arrhythmias. The reason that we are so happy to sort of invite you and include you into the SADS group is because these patients are at high risk for having ventricular arrhythmias. And when we remember, if you think about what I showed you earlier, this is a disease of the desmosomes. And so again, knowing what mutation you carry and then how you might manifest. So this is, I want to sort of highlight this. We know that, so our management style for all these different channelopathies have changed. It used to be that if you had long QT syndrome or CPVT, we weren't going to let you participate in organized sports. That's changed. We're now letting you, if we can demonstrate that we have you well controlled on your beta blocker or post-sympathectomy, we'll let you do things. That conversation is different if you have arrhythmogenic cardiomyopathy. We know that the more active you are, it can and does accelerate your disease process. So when we look at sort of current guidelines, this is truly one of the contraindications. You don't, I can't let you participate in your high level sort of, soccer because if you have ARVC. So just know that is a conversation that you're going to be having with your physician. Again, The presentation, as many of these diseases have demonstrated, can be variable. You may be asymptomatic until you're not. You may actually present with ventricular arrhythmias. I had a patient who presented with asthma, and it wasn't actually asthma. It was misinterpreted as respiratory distress because she was having ventricular arrhythmias. So understanding your own history will be really important. And so the disease may manifest truly as ventricular arrhythmias even before you start to see structural changes. Some patients have a predominant sort of structural abnormality, and they present with a myopathy, where others are going to present with sort of uncontrolled arrhythmias despite what you do. And therefore, the acceleration of your management will be based on that alone. And your echoes might otherwise be normal. Your cardiac MRIs may not be showing a lot of scar. But how we manage these patients is a little bit different in that we do exercise restrict you. Different antiarrhythmic medications will be used. You may have ablations, both endo or epicardial, based on where your arrhythmogenic substrate is, and then again ICD, and making sure we're identifying sort of affected family members. So I told the SADS team that I tend to talk quickly, and so I wanted to sort of jam a lot into today's. So this is the end of sort of my organized slides. We're happy to sort of open it up to questions or comments. I saw a bunch of chat messages that sort of jumped up, so I will let Marcia and the team sort of direct those.
Yes, we have one question that Jenny Lynn posted in the chat is complete heart block considered a SADS condition?
So I will tell you that I will let sort of Marcia and Alice and the team sort of talk about that specific, if SADS covers it, but I will tell you from an electrophysiology standpoint, complete heart block, again, is an electrically really, it's an electrical diagnosis, right? You have complete heart block, and you do need a device, a cardiac device, to sort of manage it. You're not at risk for having ventricular arrhythmias, but so it's a little bit different. But I'll let Marcia sort of answer that question specifically.
I'm not going to get into any medical things.
Okay,
we can follow up with Jenny Lynn if you want.
Sure, and I'm happy to speak to you sort of after this, and all of you guys here. Let me put this other slide up. This is my contact information. It has my email, it has my office phone number. You guys are all welcome to email me if you guys have questions about anything, or you can go directly to the SADS team, and they know how to reach me. Mm-hmm. So, but again, congenital heart block is a little bit different. Again, it can be. We do know, this is what I will tell you, again, as we're finding out more, there are certain genes, specifically sodium channel mutations, that can lead to progressive conduction disorder, right? So you might have some that presents with a first-degree block, then that progresses to complete heart block. We do know that patients that are chronically paced are at risk for developing pacemaker-mediated cardiomyopathy, so then you can develop progressive dysfunction of the actual heart muscle, and then that can predispose you to different arrhythmias as well. So please link up to an electrophysiologist, but it's a little bit different. Your risk profile is a little bit different than the disease processes that I identified in the talk. I hope I answered your question.
Thank you. Alice, did you want to add anything to that?
No, I think mostly what we see with that is like what Aarti said, and it really is a piece of other syndromes that we work with. But I also could tell you that there is not a nonprofit advocacy organization that I'm aware of that really focuses on something like complete heart block. Is more of a subset of other conditions.
Okay.
We have a couple of Brugada patients. That's great.
We do. A couple of men. Mm-hmm.
We're just catching up.
So Michelle makes a comment here. Her 1-year-old with long QT type 2 recently had a near syncope experience at a daycare mid-morning. All ER tests and 24-hour Holter monitor results led their cardiologist to believe it was thankfully a low blood sugar event exacerbated by the beta blocker. We now make sure our son has sugar with each dose of I can't say it. Yes, and so far he has been fine. However, we are concerned about impending dosage increases based on future weight gain. How do you advise your families in this situation?
Great question, Michelle. So I think it's important to make the distinction between true hypoglycemia and what beta blockers do, right? So can you have, we often do check blood sugars, right? So in patients and neonates or young, so babies that are initiating beta blockers. But what they truly do is they sort of blunt that hypoglycemic response. So what does your body do when you become hypoglycemic? It makes you tachycardic, things that the beta blocker, and it makes your adrenaline go up a little bit. So that's what the beta blocker sort of will blunt. So you can't always, you don't see those manifestations. I think actually Dr. Ackerman actually looked at this and sort of looked, do beta blockers themselves lead to a significant amount of hypoglycemia in our channelopathy, patients with channelopathies? And we haven't found that. So what I will tell you is there is ideal dosing for these medications. If I'm hoping for your son, Michelle, that this was sort of like a one-off. He might be a kid that is just, that tends to run a little bit lower, and then sort of with the beta blocker, it just might have exacerbated that. But kids, like younger kids that have issues, often won't have this issue as they get older. So I don't think this is something that you're going to have to worry about with your son as he grows up. But there is sort of ideal beta blocker dosing that should be adhered to make sure that we're protecting him from the thing that really is the most important. Can you, Michelle, not to sort of make this just a you and me thing, but is it possible that that day he just maybe didn't eat his breakfast as well as he normally does, or he didn't eat his, or something that was just isolated to that moment in time?
That's what is believed happened. As soon as he got to the ER, he had his first glass of apple juice and he was back to his normal self almost immediately. And then he wore the Holter monitor for 24 hours and his heart seemed fine. He seemed to respond to the beta blockers fine, as the cardiologist reported. So I think we're connecting it really to the medication. But, you know, as much as I understand long QT is the primary concern, I mean, if he were to pass out in the middle of the night and, sorry, my dog, lose oxygen to his brain, I mean, that's quite honestly just as scary to me as the heart condition. So I'm really torn on.
100%, right? So you just identified something that all of our families go through, right? Which is, just because you have a SADS condition doesn't mean that your child can't also have sort of normal, other normal sort of cardiac or medical diagnoses, right? Other kids are going to get hypoglycemic, but your challenge now is to sort of, and this is where we help you, right, is to say, well, was this a cardiac related thing, or is this just like every other kid? So it's a challenge. What I will tell you is I don't think the answer is ever, because I think they're having these side effects, I'm not going to take these medications, right? It's 100% should be a conversation with your cardiologist, with your electrophysiologist, and say, this is what I'm concerned about, right? And I think you bring up a really good question. So then what you need to make sure, right? And maybe what we do is we make sure that you have the ability to check your son's blood sugar at home for the next few months, just to make you feel empowered that, listen, I actually feel really good that the medication is okay and safe, right? Because the thing that we don't want to happen is that you can't go to sleep at night, right? If we are, if in helping to treat your condition, your child's condition, is now we've given you an anxiety disorder, we actually have not done our job very well. So this is about making sure that you feel good about the treatment plan, but it's making sure that the treatment plan works in all aspects of your life, your child's life.
Thank you very
Aarti.
much. Thank you.
Of course.
So Aarti, Erica asks, could you explain what long QT type 4 is? And is there a difference to it just moved.
Anchorin, yeah.
Anchorin B syndrome. Mm-hmm.
So, right. So all of the different mutations, and I can sort of pull up a graph. I actually had it, but I took these slides out, right? It's about what the mutation is and what the protein that it's affecting. If it's an ion channel, or like where in the cardiac, where in the myocyte. And so we do know that there is actually, depending on how, what ion it's affecting. So, and I think there was a related question, like, is this like CPVT, right?
Yeah.
Yes, right. So depending on where what the functional mutation of that defect is, you can manifest as CPVT, right? You can manifest as a channelopathy that prolongs the QT interval. So it'd be important to look at your the actual mutation and looking where it is and then how it's going to clinically manifest. So this is why I don't want, the more we learn, the more we're also understanding that sometimes it's very obviously black and white. And sometimes you may have something called a VUS or variant of unknown significance mutation. So it's always important. One of the things we'll always do for you and your family is try to connect the clinical manifestation to the actual mutation. So you don't necessarily have the diagnosis just because you have this VUS mutation, but just because you don't have genetics does not also mean you don't have the disease. So it's important to always make that link. So I think if you want, I'm sorry, I missed your name again. Erica,
Erica.
If you and I, if you want, we can touch base afterwards and sort of look at the what you have in the mutation and then try to put that together. Or if if you tell me who your electrophysiologist, I'm happy to sort of start that conversation as well.
Okay, thank you. So Jeff said he was diagnosed with ARVC at age 55 after being an exercise nut in all his life. He says, does that speed up the progression?
Yeah, so it's a great question. And yes, so what we have found is that patients that have been really active in their life will have an earlier presentation. Does that mean every patient that has ARVC because they exercised is going to present in their 20s or 30s or in their teens? No, right? But we do know that it accelerates it. But let me tell you, that also does not mean that I'm giving, if there are teenagers out there who have ARVC, that doesn't mean I'm giving you license to become a couch potato, right? We're not sort of going to replace one disease with the other. But we do know that is why we recommend that patients that do have gene positive ARVC, we're not going to sort of give you the sort of that clearance to just become a collegiate level athlete who is involved in sort of organized sports. So the short answer, yes. And then the long answer, what I just told you.
Okay, thank you. Debbie asks, or comments, my kids have mutations in their FLNC genes. They have ICDs. Is this a SADS condition?
Debbie, I have to apologize. I'm not sure what is the I'm unaware of the FLNC gene. I can quickly look it up, but if I can understand, if you tell me do you know what was the diagnosis that they gave your children? Do you know?
Mm-hmm. Can either put it in the chat, Debbie, or if you want to unmute yourself.
Okay, I'm unmuted.
There you go.
Their mom and my daughter, my son, and my husband all dropped dead suddenly as young adults. And so they just did this genetic test about 3 years ago, and it said that this FLNC gene causes sudden death.
Yeah.
Well, which is obvious to me, but they say it's mostly associated with myofibrillar myopathy or dilated cardiomyopathy or distal myopathy. But the older boy, his almost 12, he has arrhythmias. And so that's why I thought, well, maybe it is a SADS condition. But the younger one, they both inherited it. The younger one was once diagnosed with cardiomyopathy, but he's been on medicine all his life and he's not had arrhythmias. So I don't know.
So I think it's a new, newly found gene, right? And so they're not really sure where to place that or what all the pieces, but it is in the cardiomyopathy side. And it also is something that, well, Aarti can tell you that cardiomyopathies don't mean that you don't have arrhythmias, right? Like you still have different arrhythmias because you have something that is affecting the heart muscle, that mutation, right? So then it gives you an arrhythmia. So, but it is a brand new gene find that I know is part of the genetic counseling lexicon now, and they're looking into, and there's some papers written and all that. That's why it's new for you, Aarti, that it's not, just I don't think they yet know that much about it.
So then,
But-
Debbie, I think the answer is yes, right? So when we talk about, is this a SADS condition, right? Or a SADS disease, right? I don't want you guys to think if you don't have one of the known and identifiable sort of diseases that you can't be sort of part of this club. It's if you have a disease that puts you and your family at risk for sudden death, that's inherited, right? It might not be that we might not have a crazy amount of information to share with you, but we can at least empower you with having the proper support. Because Debbie, I am so sorry about the history and your family's experience. Devastating. But so how do we make sure that we, is there a way for us to help make sure this doesn't happen again? The ICD is a really good thing. But then also putting you in contact, because if you are somebody with this, we might have another family across the globe that has it, and sort of helping sort of make that connection. So it might not be the same amounts of sort of resources that we have, but we can also help look into people that know more about this, right? So, I mean, this is a great example. I don't know about every mutation that's out there that's also just come out, but part of it is saying that I also know that this is what we need to do for someone that, for example, so this is what Alice was referring to. You can have diseases that only result in arrhythmias, but completely normal function of the heart. You can have diseases that destroy the function of the heart as a pumping, right, as a pump, and may not lead to arrhythmias, but maybe later on will. So they're connected though, because you need the rhythm to dictate what the heart muscle does. But if the muscle becomes too thick, too thin, scarred, it's going to cause, it's going to affect the way the electricity goes through the heart, and therefore then will lead to arrhythmias. So medication, so that at the end of the day, the tenets of how you treat this is going to be the same, right? You want to make sure it doesn't happen again, which is an ICD, right? And you want to make sure that you can try to control those arrhythmias with medications. But remember, every medication can have a side effect. So you want to make sure medications that we put on start don't affect the cardiac function. So it's a complicated conversation. Debbie, please make sure that you and your family are linked to an electrophysiologist and that you're having this conversation.
And,
Okay, thanks.
and Debbie, you can note, Keith posted in our chat, there's a link from the NIH resource about the FLNC gene. So check that out in the chat field.
Oh,
And
okay,
he
That's
thanks.
put-
the muscular dystrophy page.
Is it?
I haven't gone to that link, but I think that's what it, but I think that there is also a new registry where they're looking at types of muscular dystrophy and other myopathies and cardiac and the interface. So I think, as Artie said, we definitely have those researchers and those experts. And so when there are updates, or if there are things, if you stay in touch, we can help with that as well.
Okay, thank you.
So Elliot posts, let's see, went back up here. I lost it. Brigada, his daughter. Yes, his daughter has, or he was diagnosed with Brigada back in October. And his daughter has an appointment at Children's Primary in Salt Lake City next week. Are there any early warning signs that we should be aware of?
Yeah, so I mean, I think with all of these sort of inherited arrhythms that we're talking about, the things that you want to think about is, has your daughter sort of complained about sort of palpitations, racing heart rates, and then like with complaints associated with, dizziness, feeling she's going to pass out? Has she passed out? Has she had symptom or anything that looked like seizures in the past? So things that would make you think that that might otherwise have been overlooked is actually related to the development of a cardiac arrhythmia. So when we talk about seizures, I don't want you to think now you have a coinciding neurologic disorder, but you can have seizures because if you go have an arrhythmia, which then is resulting in low cardiac output, you're not getting enough blood to your brain that can manifest as a seizure, right? So, but those are the things, right? So if your daughter's like, you remember like as a child, every time she'd get the flu or every time she was ill, you'd notice that she was complaining about her heart racing or she was having trouble breathing if it wasn't pneumonia, right? So thinking about things like that, they will at the time of diagnosis get an EKG and then go up and do a higher rib space to see if they can bring out that spontaneous pattern. Elliot, I don't know if you have, for your Brugada syndrome, one, what type you have, first of all, and then two, if you had sort of that spontaneous EKG finding. But they'll do that and they'll look for all that. And depending on, you know, your gene, I'm assuming you're gene positive. Is that right?
Yes, I was gene positive and I am type 1.
Okay.
And when my genetic testing came back, my electrophysiologist said they have never seen my genome yet with my diagnosis. So he was completely confused as to what was going on here, because he did a procainamide challenge on me and I popped positive for it. But I've never myself have had issues, but I have had chronic pneumonia since I was 7 and I'm now 36. And I get pneumonia at least once, twice a year. And
okay, so unrelated. So pneumonia. So let me clarify. So pneumonia is not gonna. You don't have more pneumonia because of Brugada syndrome. What I meant to say is, if she, like, every time she got sick, there'd be symptoms suggesting cardiac symptoms. So that should not. Your pneumonia should not be related to your Brugada syndrome. So clarify for me, Elliot, and I apologize. So they diagnosed you after an abnormal procainamide challenge. And how did you present? What prompted the procainamide challenge?
abnormal EKGs at both my primary doctor and then when I started seeing the electrophysiologist, it was abnormal EKGs that presented saying, hey, we need to do further testing on you for this.
And then why did you get the EKG in the first place?
My brother presented with a right bundle branch block, and I just went in for a normal EKG baseline at that point saying, hey, what the heck? Why not?
Okay. And so then you had abnormal genetics, and then they tested your daughter and she carries the same mutation?
We're going to find that out next week.
Okay.
She is, and it's very hard because she is only 5 years old. No, she's only 4, sorry.
Okay.
So yeah, she could say, Daddy, I don't feel that great, but I don't know, you know, that's why I asked the question. It really, she rarely gets sick, but is there anything really that presents that would help me understand what a 4-year-old is really going through who can't properly communicate what's going on with her body at this point?
Sure. She's not going to tell you, hey, Dad, I think I'm having DT, right? Not a conversation she's having. But if you're like, you know what, how come my little girl like passes out all the time every time she's sick, or, you know, why is she doing these like weird movements when she's like sleeping? Why does it look like she's having a seizure? I think what I would do to make sure that your daughter's appointment goes, you know, is as fruitful as it can be, try to go with that, with your genetic report. So then they can sort of look at that, and then they'll likely have you meet with the genetic counselor, which, again, as mentioned earlier, this is a team sport. And so making sure you have all those pieces in place would be super helpful.
Yeah, we are going to meet with genetic counselors while we're down there. And then my electrophysiologist has forwarded all my paperwork for them to review down there even before we go and see them.
Great.
So they have my complete history, everything like that there.
Great. Yeah. So you're going to a great program. So I have no concerns.
I think the other good thing to know is that with Brugada syndrome, most of the time, kids that are 4, or, you know, the young kids are not kids that have events. It's when you get older that usually, I mean, it's not 100%, but usually it's when you get older. So at least it's a little peace of mind until you get to see the docs at primary.
Mm-hmm. Okay, we have another question from Nicole S. If you have a defibrillator, should you also be taking medications with long QT2?
Yes. So the recommendations are that you should be on a non-selective beta blocker, even with long QT2. So Nicole, I'm assuming that you had an event and then got a secondary prevention ICD. Is that correct?
No, I've never had an event.
Oh, but you have a defibrillator?
Correct.
Okay. So there's certain reasons why, right? So we, part of the reason I had sort of early on put some of the scientific papers on is I don't want you to think people are just, you know, coming up with some of these recommendations. It's really, we come together as a group of sort of professionals to say, this is what is the best thing for these patients. And so I would recommend that, well, one, you can ask the question. I'm not sure who's following you, but you might ask why you're not on a beta blocker, or if you are, if it was prescribed and you've chosen not to take it, I might reassess.
I was, and then I wasn't like happy with it. And then I had recently asked if I should be on it because I also have thyroid issues.
Mm.
So my levels sometimes speed up my heart rate if they're not correct. But
Yeah.
my electrophysiologist said that I don't need, that he doesn't recommend medicine unless I happen to have an episode because I have a defibrillator. So that should be good enough.
Right. So I will tell you, this is my motto about defibrillators, right? You don't put a defibrillator in someone so then you feel better about them having events, right? You put a defibrillator in someone because in the event that they have something, you want to be able to save their life. You should not use it as a prevention model, right? So, Nicole, what I would say for you is you want to make sure that you are being optimized on your medical therapy. And then if you happen to need the device, then it's there to save you. But it's not meant to be a, well, now we can do whatever you want. And then if you happen to have an event, then you have the defibrillator. So my recommendation would be that you should be on a beta blocker. And maybe you don't have to be on 40, maybe do 20 of Nadolol, right? But it's important that we have you at least marginally protected.
Thank you.
Okay, a question I missed earlier, Tara and Sammy. My daughters and myself are newly diagnosed. Doesn't say what, with what. How would the EP be able to tell when we reach the proper dose of beta blocker? We are laddering up slowly and asymptomatic.
Great
Long
question.
QT1 is what they have.
Okay, perfect.
Thank you.
So what we'll often use, right? So we'll use different monitoring. So like, for example, like Holter monitors to sort of understand what your heart rate trends have been. And we typically, and things like stress tests. So stress tests give us other information as well. But at the end of the day, we try to blunt your peak heart rate. And so by knowing what your average heart rates are and how, through things like Holters, again, stress tests, we'll be able to see that we'd be adequately beta blocked to know that you're getting appropriate therapy. It is sort of, we do weight-based therapy when kids are quite young. And then when you get to be closer to adult size, then we try to get you more closer to ideal dosing. So anywhere like the 40 to 60 of a non-selective beta blocker.
Okay, I love this.
Milligrams. I apologize.
Mm-hmm. So Lauren says, I was diagnosed when I was 2 weeks old and I'm quite happy. So stay positive.
Right. I mean, Lauren, thank you. I think you, again, this is the point of this entire series, right? Is to say, you do have a SADS condition? Yes. But guess what? Like we can help you manage it. You can live a great life. And then look at how many people are on this call. I don't know how many people are on this call, but you are surrounded by a community that is either learning how to do it or has done it. And then, we have a conference every year that can put you in touch with people that have done this really well for a long time. So yeah, stay positive. I agree with Lauren.
Lauren is from Germany. She has long QT1. She was diagnosed, 17 years old. So far, everything went well. Thanks for the great insight here today, as we don't get much information in Germany. So,
well, welcome.
Kudos.
You're welcome to email me, Lauren, as well. Even though, again, internet. The good thing about the internet is cross-continental, right? It's intercontinental. So
that's right.
Anytime.
Any more questions or comments here that you'd like to put in the chat, or raise your hand and verbally ask your question? We're open to that. Any feedback from today, we appreciate too. Thank you, Keith. And thank you, Dr. Dalal. Excellent presentation, Keith says.
Thank you. It's, again, you guys, I have so much fun sort of being part of the SADS organization. I think Alice and Marcia sort of let me sort of weasel my way into being part of like the education committee and stuff. So the point is, this is the people that are part of this organization, like you, we're very passionate about making sure that we're doing the best thing for this community. So it is, reach out to us. We may not always have the answer, but we're going to find it for you if we don't. And then we'll put you in touch with people that can. So.
Oh, here's one more question from Michelle. How do you help children communicate to their peers that they should have that they shouldn't be startled, like on the playground or whatever. Yeah.
Great question. So I think I think my answer is going to be twofold, right? One, which is part of it is when they're super young, you can't really explain anything, right? But the second, as they get older, part of why we do these education sessions and why we want to make sure our kids, right? So when I actually even have young kids, I have a sort of a version of this talk with them, which is, let's talk about your diagnosis. Let's make sure you understand it. Let's make sure you understand your risk factors, because then they can talk to their peers about it. So even offering to say, hey, listen, and I do this all the time, you know, can I come out to your school? Do you want me to come out to your school and talk about the disease? So then the people who are there, or, you know, around your kid knows what, you know, what the diagnosis is, and not in a way to say, oh, look, this is what you have, but rather like, let's make this something that we as a community want to embrace and talk about, you know, making sure that the school is a heart safe school, and let's educate them. So one is like educating, but then two is we do not want your kid to exist in a bubble. So will your kid get scared? Yes, 100%. Is your kid going to get angry? 100%. So the reason medications and things like that are really important is because we want to try to use it as a way to control risk. So when life happens and your kid has a tantrum, or your teenager gets really mad because you didn't let them have the car, right? They're not going to have an event. So part of it is education. The other thing is making sure that you're just being good about the preventative care that we're instilling to make sure that we can mitigate the risk of having a cardiac event.
Thank you, Aarti. We appreciate all your feedback today, and thank you for all attending. We have scheduled, as Aarti says, the January calendar, but we have one more that we've added. The Long QT 3 is going to be on February 2nd in the, I believe it's 2 p.m. Eastern time, presented by Dr. Arthur Wilde from the Netherlands. So the others are all on our calendar, and I know most of you have signed up for the specific condition, and we are planning others for the future in February and March. So stay tuned and keep updated on our SADS webpage. Are there any other questions before we conclude? Comments, chat, please add your feedback. We appreciate it. And if you'd like us to follow up with you, let us know. You can reach us at sads@sads.org. And thank you very much, Aarti, for presenting today.
My
We
pleasure.
appreciate it.
Thanks for having me.
You bet. Slideshow was fantastic, Tara and Sammy wrote.
Well, I'll talk to Marcia and the team, but I'm happy to share my slide deck if you guys need them.
And this is recorded, so it'll, you know, you'll be able to view the slides again from the recording if you want to check it out later again or hear it again. Okay, folks, we have 3 webinars next week, so I see some people are joining for us next week. Anna, did you want to add anything? No? Okay.
Nope, that's perfect.
All right, thank you. Well, I think we can conclude today unless you all would like to chat amongst yourselves. I know our specific condition webinars, we're going to have time for chat for the community for like Long QT1, Long QT2, Brugada, et cetera. We have time allotted at the end of the webinars for you all to get to know one another within your condition community. The recording is going to be on sads.org, stopsads.org website in maybe a couple days. And Alice has posted the schedule that we have so far, the dates. You can see those in the chat. Thank you, Alice.
Sorry, just so late. I've just got 2 computers going here, so it's
I understand.
confusing me.
And there's the website, Living with SADS Family Webinars. We will post it right there on that link.
All righty.
All right.
Thank
you
you.
all for spending this evening, this last almost hour and a half or hour or so with us. We appreciate it very much. So, and we look forward to seeing you soon on another webinar. Take care. Thanks, Aarti. Bye-bye.